Hello, I'm Mally Shansfeld, Managing Editor for Orthodontic Practice US, a Medmark publication. Welcome to an educational presentation and question and answer entitled Smart Aligner versus Traditional Plastic, Moving Teeth with Fewer Attachments with Dr. Bill Layman. Before we get started, I'd like to invite everyone to use the question and answer feature in the control panel to ask any questions, and they will be answered at the end of the session as time permits. After the webinar, we will email all registrants the recording along with instructions on how to access the free CE quiz to receive your certificate. Now I'm pleased to introduce our speaker. Dr. Bill Layman is a nationally recognized orthodontist, passionate about delivering efficient, patient-centered care that creates life-changing smiles. After graduating cum laude from the Citadel with a Bachelor of Science in Biology, Dr. Layman served as a paratrooper in the U.S. Army's 82nd Airborne Division. He went on to earn his doctorate of dental medicine from the Medical University of South Carolina, followed by orthodontic residency at Vanderbilt University. Recently, he earned his MBA from the Wharton School of Business at the University of Pennsylvania. An active educator and innovator, Dr. Layman collaborates monthly with orthodontic residents at the University of Florida and speaks nationally on digital orthodontics. He's a member of numerous professional organizations, including the American College of Dentists, and regularly advises colleagues on integrating new technologies that enhance accessibility and patient care. Thank you so much for joining us, Dr. Layman. Now I'll turn it over to you to learn more about today's topic.
Thank you so much for that introduction. Sometimes when I hear that, it's sometimes hard to believe, but I really do enjoy the opportunity to share with others. Once again, she kind of went over all of these items already. These are just kind of some fun pictures of my wife, my family, my team, and in 1992, a young orthodontist right before his first jump, being stupid enough to smile. So it's kind of interesting. You got to show those teeth, right? It's a lot of fun. Today, the topic we're going to talk about is direct print aligners. I've treated over 70 cases of direct print aligners from start to finish and have really enjoyed the process. And I'm looking forward to sharing this process, sharing some of the tips and tools that I've learned, my workflows for that. And I'll show you some patients that I've treated and how much fun we've had learning and enjoying this process. We're going to go over what are direct print aligners. What is that? How do we categorize that? It's a whole new category of items that's emerged recently. And what is the future of clear aligner therapy, patient cases, and my workflow? Direct print aligners are nothing more than a smart plastic. I mean, think about that. There's dumb, I call it dumb plastic and smart plastic. It's the ability for a piece of plastic to just form over something that you designed versus being able to actually create different opportunities in the plastic, which makes it smart. I currently use a DCA appliance by LuxCreo. I don't have experience. I know there's a couple others in the marketplace. This is the one that I have experience with. So I will be talking about this type of plastic. 4D aligners, it's the first smart clear aligner that we're working with. The key features of a 4D aligner. You have the opportunity to customize the thickness per tooth, and within the tooth, the variability to create target force applications. Because we're able to grab the tooth and have a direct print accuracy, one of the big things that I'm really enjoying working with is the fact that I can have no or definitely much fewer attachments with this type of material. And the fact that traditional plastic versus this smart plastic deforms over time. And so we're going to talk in a little more detail about these types of items and how I'm benefiting from it and how to implement this into an orthodontic practice. I think it'd be tough to talk about the evolution of aligner therapy without going back to the beginning. Evolution, as we've seen these images many times, the very beginning, prior to the digital revolution of aligner therapy in the late 90s, mid 90s, late 90s, we essentially would have to make a stone model, separate the teeth, and then sequentially move the teeth, making a thermoform on top of that. This was a destructive process, and it was a very, very labor-intensive process. If you needed a small movement or just a little bit of a change, you could do that. You could make some resets in the stone models, make a tray that would then put the teeth hopefully into that position. We had the ability to use different pliers to make little bumps in the trays. All of these little things worked well, but were not scalable at all. In the mid 90s, thermoplastic science and the ability to actually move teeth with these aligners became scalable because of the digital format that occurred. Now, in thermoplastic science, you're seeing some of the items in this video, how the tray itself, when heated up and then stretched over a model, can create gaps where the attachments are. We're going to address that and how direct print solves that, and also the variability on the thickness of the tray is high. We don't know exactly what we're getting. So we're having to move teeth and treat patients based on a set of circumstances that we don't really have a lot of control over. We just respond in the form of multiple refinements to get the teeth kind of where they're going. I'll tell patients very frequently that when we use braces, we're telling the teeth where to go. And when we use aligners, we're asking the teeth where to go. So having a more considerable ask by using a smarter plastic really helps reduce, I believe, those variances, that extreme variability that occurs when planning a case, going from planning to execution. So original aligners, if some of you may remember, really did not have attachments as part of their ecosystem, because who wants to have bumps on their teeth? This whole thing was developed in the mid 90s because they were trying to create a very aesthetic type movement. Now, late 90s, early 2000s, I think the industries realized that, well, these teeth just really aren't moving. There's a drawback in the thermoform process of creating trays that we need to overcome. So what happened was we made aligner attachments, and the aligner attachments themselves became better. We had different techniques. We had many people that were testing attachments, coming up with new attachments. And then, the ability to then take attachments that were just kind of, once again, dumb bumps on the teeth and trying to make smarter bumps on the teeth. All of this was in an effort to create the ability to create and overcome the drawbacks of just a thermoform piece of plastic because of the increased variability, going back to that, and the fact that we weren't really sure how the trays were going to fit, and parts of the tray, mostly in the gingival third of the tooth, not engaging very well because of the manufacturing process of trays. So attachments, so going back using stone, let's scale, make a digital piece. Let's not use attachments in the original aligners. Well, that's not working. The teeth aren't working. We have laterals disappearing. We have teeth not tracking really well. So let's add something to the teeth mechanically, biomechanically, that allows a ledge so that that plastic can actually affect the change on that tooth that we're looking for. Now, if you have a fully modified resin tray, which is what we currently have now, can we overcome the original issues with just thermoform plastic and engage the teeth much smarter and much better, thereby evolving out of the need for attachments, which, like I said, were in response to the shortcomings of thermoform. And so that's where we are now. So the evolution of that brings us to a point where we're actually able to hopefully evolve out of having to use so many attachments on teeth, which I think is really exciting. What's it going to take? What is the future of clear aligner therapy? Well, the future of clear aligner therapy looking forward, I feel like is going to be a fully customized aligner tray. The ability to make this plastic not, we've had fully customized setups of the case, but once again, a lot of those setups are just trying to overcome the shortcomings of thermoform. And because when you thermoform a model or thermoform over top of a model, that tray that you're thermoforming still has inconsistencies that are just inherent in the process of heating up a piece of plastic and sucking it down or creating positive pressure on that. So a fully customized tray gives you so much more control over what's happening. And I do believe that is going to be the future of aligner therapy as a whole. What will it take to make this a reality? We need a lot of research. And I mean, when I say research, I mean the fact that guys like myself and other people in the field are doing research. Other people in the field are treating cases. And a lot of times I think research is very important Because if anecdotally I say, you know what, I did this on a bunch of people, it worked really well, that's great. Research, in my opinion, allows the organization as a whole, allows the profession as a whole to really dig down and understand the mechanics of why it worked. And if research can show that and can be replicated over different providers, then we're really onto something. But if one person does something and says it works and nobody else can get it to work, that's unfortunately sometimes what happens in our profession, and things move on and we hear great ideas, but then it moves on. But if we can get something that shows it works and then multiple people can verify that it works, then I feel like we truly are evolving into a different efficiency frontier of what we're able to do. Um, Direct print aligners are improving. We have better engagement of undercuts, and the range of activation is better. You can see the difference in the actual fit of the trays on the direct print side versus on the thermoform side. You can see how the interproximals, of course, a thermoform plastic is not going to engage as well just because of the way it does it. And you'd have to melt the plastic too much to get it to really engage those undercuts. And then you completely lose a lot of the functionality of that plastic. So once again, some shortcomings of thermoform that are overcome by the ability for a direct print. You can have multi-thickness control. We talked about that briefly on one of the slides. We showed it, the ability to have a tray, and this is going to be one of the projects I talk about, the ability for the tray to be different on the occlusal surface, on the gingival surface. In one area, we're going to talk about negative attachments. You can create thickness, you can create bumps, all those different things. So having the ability, your mind can then go to wherever you want it to go, the ability to make this plastic do what you want it to do. I mean, that is kind of the biggest point that I want to make, is you now have complete control over it. And a lot of these things are still in a position to where you really want to be able to play with this, and we need people doing more research on this, because I'm sure everybody out there is going to have amazing ideas on their clinical challenges, and if they had this ability, what could they do? Well, let's put it together. Let's look at this. Let's get the information together. Let's find a way to communicate how you're solving that problem so that everybody else in the profession can benefit from that. What happens? You can see on the top right photo, what happens when a patient comes into an appointment and they've got the trays in their pocket? How well do you think that tray is working? You can answer it. I personally don't think it's working as well. The day I give somebody a tray, that's the last time that tray is exactly the way I want it to be. It's going to deform. It's going to change. They take it in and out. They grab it with their fingernail. They throw it on the counter, stick it in their pocket, leave it in the car. All of those things affect the actual dimensions of that tray. So if the dimensions of that tray are telling the teeth where to go to track properly, if the dimensions of that tray change, it's not going to move the teeth where you want it. That's just a drawback. That's a shortcoming of what we have right there. With the direct print aligner type materials that we have, if a patient puts that tray in 99 degrees Celsius water for 5 minutes, that tray rebounds to its exact shape. And so typically over a 7-day wear, I'll ask the patient at day 3 or 4 to put it in some hot water. And I know that that tray is right back to where I wanted it to be, and then they wear it. And I really would like to see a reduction in refinements. I'm currently working on some projects with that with the university to try to really get enough data to show that there's a nice change there. But that's a big part of what this full shape and force recovery can do, especially me. I live in Florida. So living in Florida, having heat, uh, a tray that likes the heat, I think is pretty great and likes to be hot. So one of my first research questions I was looking at, and I'll show a few patient cases. I haven't finished this yet, but can we avoid? It was one of the questions. We've talked about, attachments being an adjustment to a shortcoming of thermoform plastic, and the question is, can I avoid attachments with LuxCreo or with DCA aligners? You know, so what I decided to do was do a split mouth study, and like once again, we're still working on it. We're still finishing it, and the fact that I can put negative attachments on the left lateral and put a regular attachment, or I like the attachment that I use with my software, on the right lateral. If the laterals track similarly, or the left lateral is improved or the right lateral is improved, gives me the data points to help understand what's happening. And I use the laterals because there's a large body of research that shows that the laterals, the V shape of the tooth, the limited height of contours, are difficult teeth to move. If you have a practice, any type of practice, GP, ortho, whichever, and you've tried aligners, you likely have struggled with lateral incisors, extrusion of them, rotations of them, torque control of them. You likely had an issue. So that's why I chose the laterals to do a split mouth study on, because I want to see, does it work? And did I start with massively torque needing laterals? Did I start with super extrusion? No, I started with laterals that can I just hold them in the same spot? Because when we squeeze a lateral, if we don't have something there, there's a chance that that lateral will intrude, the disappearing lateral, as it's been coined in a number of articles. And so you can see how we set it up. On the left, you can see the actual verbiage that I used, and on the right, you can see the setup that I used for the cases. Now, here's what happens. A negative attachment can create a precise pressure point. You can see here on the digital side, when I create a negative attachment in my aligner software, a negative attachment, pressure point. Negative attachment makes sense to me because a positive attachment comes out from the tooth. A negative attachment goes into the tooth. So for me, it's kind of easy to keep up with the two different types right there. And you can see what it does digitally. Now, the question is, does something like that digitally, what does it matter? And what's the difference between doing this type of thing on a direct print aligner and doing it on a thermoform plastic? This is what it looks like when you print the model, those negative attachments you can see. And once again, you still are engaging the tooth in a way, but you don't have something to put on the tooth for the patient. So you can see on the right-hand side, this is the actual direct print aligner printed, and you can see how well those small negative attachments print it. And the goal is that those attachments will grab what little height of contour the lateral does have and engage that tooth. Also, the plastic itself really forms to the tooth, so you don't have the issue with the gingival third of a thermoform not really engaging very well. And the spring back design, that when people take it in and out or play with it, it pops right back. And also heating it up augments that, which is really good. Here you can see the exact same model that I used. Well, I used the digital file to create the aligner and then print the aligner from this model. This model I printed, did a thermoform, nothing. You can see there's nothing that really you can tell that you even put this negative attachment on there. So if you put these on and then do a thermoform, you're not really getting any benefit from this design that you put in there. You can see the difference between the direct print aligner and the pressure points or negative attachments that are in the tray versus the thermoform. And so this is one of the studies. I got a couple cases I'll show, some diastema closures, because that's a real squeeze and intrusion a lot of times on the upper 2 to 2. And so, my hypothesis would be that if I didn't have some sort of positive control over that lateral, I likely, based on a lot of research I've seen, would lose that lateral, or there'd be a change in the incisal edge. If I had an attachment on one side and no traditional attachment, but this type of attachment complex on the left side. Something else I wanted to look at, and I'm starting to look at, is the multi-thickness in direct printed aligners. So I can change different things. This is a study by the AJODO that shows the predictability of expansion with Invisalign. You can see on the right, I kind of summarize a lot of the numbers. What this means is that when I go into my ClinCheck or a ClinCheck and I expand, let's say 10 millimeters, I'm only going to get 7 in the canines. Now, 10's a big number, of course. I'm using it for easy math for the thing. And first molar is the same type thing. Now, what is that a function of in the upper and lower? Is that a function of the teeth themselves won't expand? Is that a function of the fact that I've planned a case and there's a lag? And what is that lag based on? Is that lag based on I'm not able to create enough force in the aligner to fully affect that? Well, I'm creating force. It's obviously happening because I'm getting expansion. So what's the lag come from? There more likely is a force dynamic that doesn't happen. So now, can we make the aligners thicker? so that you get a little better force dynamic, a little stiffer appliance. Like it's like using a tie wire to expand versus a stainless steel or beta 25 width to expand. All those kind of basic concepts that we think about as orthodontists as we're planning cases. But a patient may not tolerate a 1 or 1.5 millimeter tray thickness all the way around, but they very well may tolerate it right on the edge of the lingual edge. So if you can make that lingual edge of the aligner a little bit thicker in that respect, are we going to see an improvement in the numbers between what I planned for expansion and what actually happened? Well, working right now, working on getting a university to scale this study up so that we can have a really nice project with different providers and different scenarios so that we can take the traditional aligner studies, like for instance, maxillary canine showing a 72% change. If using smart plastic to make changes to the force dynamics that are available, are we going to get a better expansion or a more predictable expansion when we set our cases up? Once again, right now, the initial data that I'm looking at, it looks really well. Projects will be coming out over the next 6 months to a year, hopefully showing in much more detail and the ability for somebody else to replicate that study to really show that we are able to have a more predictable movement by using smarter plastic. So you can see here how it's set up. You can see the different sizes, the different thicknesses. I can have a thinner occlusal surface, a much thicker lingual band there to affect expansion. And this is just one. I had a talk in Texas earlier this year, and we filled up a whole board of ideas people had. And that's the beauty of this, is that if you have an idea on how you'd ever want to change the tray itself, it's now available to you. And that's what I think is so much fun about this. It's like the ability to start using aligners in 1998 and grow through that process, and some of the great instructors and research and publications we've seen from those individuals that really got in early and helped develop that concept. I think now you've got the opportunity to get in early and really have a lot of fun doing this and participate. So expanding the frontiers of no and fewer attachments. So, this is taken from Kevin O'Brien, who was taken from Farouk Ahmed, and, some of the different predictability of movements. This is a nice graph that showed the actual predictability of movements based on what's happening in the case. So you can really see here some of the opportunities we have to really reduce the type of attachments that are on case. Now, when I say no attachments, I mean not having to put a button or a composite ledge on a tooth. We looked at expansion. We can use the pressure points, negative attachments for that, distalization right on the buccal and lingual mesial aspect of the tooth is going to push back very nicely. Now, as far as controlling tip, you can also add pieces for that too. And it doesn't mean you're never going to use attachments in these cases. I'm by no means saying that I never use attachments. That's not true. Some of the patients you are going to see, I use attachments. And sometimes on some of these cases, I use a little more just because I still kind of go back to what I know. But as we continue to develop, as we continue to, for me, have a proof of concept that it's working predictably, I will slowly start to remove attachments, because at the end of the day, I'm in private practice and I want to make sure I'm doing something for my patients that I feel is based on some really good science, or in this case, something that I've seen work really well. So I'm doing small tests throughout of items I feel like have a very high predictability without the attachments. So patient communication, sometimes we have people that say, well, my friends had a bunch of bumps. Why don't you have any bumps? Or, we want to be able to use a plastic that's a little smarter. It actually grabs your teeth a little bit better. When you direct print something, this is one of the biggest things, patient communications we talk about, that's daily being improved upon, is the fact that when you 3D print something, you have layers. And when you have layers, you have an opportunity for small micro ledges. And if somebody's hygiene is not exactly where it could be, they definitely will show a little bit of staining on the tray sooner than somebody else whose hygiene is good. Using like a hydrogen peroxide based mouthwash, using a 3% hydrogen peroxide rinse on the trays wipes out that layer. But if somebody is seeing some staining on the trays themselves, it can be, and there's been a lot of internal research done on that that shows that when you follow the protocols, the staining is almost completely reduced. But if you're drinking, tea, coffee, Coca-Colas, things like that with your trays in, likely there's going to be a little bit more of an issue than with thermoform. But it's also an indicator to what's happening inside the mouth. So if anything, it can be a nice hygiene wake up call, like, wow, if I got that much stain, that's what's happening to my mouth. Let me clean these off with some hydrogen peroxide. Let me start rinsing with a oxygen based like TheraBreath or other items like that that can really help, non-alcohol based type rinses that can really help with the staining that's going on, and also with the staining that inevitably will happen to your mouth and to your teeth. The trays give you a good leading edge on that. We start a lot of times, I may have to add some attachments. Going in and telling somebody, I'm never going to use attachments is kind of like saying I'm a liner case, I'm never going to use braces. Sometimes we go in and we do have to add little things here and there. We have to, as an orthodontist, maybe even GPs, but as an orthodontist, definitely, we have a wide use of auxiliaries, buttons, uprighting springs, outright braces, limited braces. If I tell a patient that needs the lower left 7 uprighted for a bridge or for an implant, we may be able to design a system with aligners, but I definitely tell them, like, look, there's a good chance that this can work with great compliance with if you're compliant with wearing it and your teeth are compliant with moving like we want them to, but likely we may need to put a couple small brackets to get that final little piece. Same thing here. With this material, with this technology, we have the ability to reduce attachments dramatically, but can we completely eliminate them? I'm not sure. We're going to get into your case and talk about that. So what I'd like to do now is talk a little bit about my workflow. I'm going to take you through, like I said, I use the LuxCreo system, so that's what I'm familiar with, and that's what I'm going to talk about. And the workflow, we're going to talk about exactly what happens from scan or importing data from the scan all the way through the actual tray being ready to deliver. Creating aligners. What you're currently seeing is the ULab software. There's a few softwares out there. This is the one that I use exclusively to create the actual tooth movement and how I'm going to do it. You can see here on this case, what I'm doing is I'm adding some negative attachments on a case. We'll show this case in a little bit. That needed, really the patient came in because the periodontist referred the patient to me because the amount of recession and the position of the root was not very predictable for being able to do a graft right there. So the periodontist would like for me to torque the root a little more lingually to create a better environment for a graft in that situation. So that's the software that I use to create the aligners. And then once that's done, you can see at the bottom, it's going to be 6 trays. And then what I do is I export those in the form of a no mounting fixture and direct print aligner. And we use a XML file, which gives us the ability, you can see how the cut line is already there. I can adjust that cut line before I send it. But essentially, I'm sending the trays out to a place where I can use it. The PTS file that you see on the bottom there is the trim line file. And the 6 above it are the models that the next software will use to create the actual aligners. I use what's called LuxDesign. It's a software where you can essentially import STL files, and I use a program that allows me to import STL files and the PTS file. There is a format now called an XML file with ULab where I can essentially import just the XML file. The XML file is going to tell the LuxDesign software where the STL files are, where the PTS files, and with that, I have the ability to also have it automatically add the number of the tray onto the direct print aligner. Because even though the number for the model, the tray series is on the tray on the model itself, it doesn't transfer very well. You can't really see it in the direct print aligner, depending on the thickness, of course, but it's not really going to show up well. So we actually have an emboss number that goes onto the tray itself. And then printing preparation, we can see here, we bring the trays over from LuxDesign into the LuxFlow software. That's just like anything else, Rayware, any of these types of things. And you can see that the trays themselves are developed, they're designed. This was all done through an AI process that Lux Design took the models and made the trays for me, which worked out well. Now, in this situation, what we're doing is this video was taken before the XML process, which is pretty new, and I would go in and actually label the trays themselves. You can see how that's working. This process was a little bit laborious, but has been updated now through the ULab LuxCreo interactions or handshakes that are happening, which is really nice. So now we have a situation where we have our trays ready to print. The thing I want you to notice on here is that the supports are only on the edge of the tray. There's no supports on the occlusal surface, no supports on the intaglio surface. You can't really tell here, but the supports themselves only are on the edge of the tray. That's important because when we start processing the trays and printing them, you can see how that comes out well. You just scrape right off. You always put the trays in the wash in a way where the intaglio surface is down because, and something else on the print process, you don't want the trays hanging there very long because the resin itself, the way the tray comes up, the intaglio is facing up and the resin can sit in there. So if you leave it overnight or over the weekend, there's a high chance that the trays won't fit as well. There'll be some distortion because it's not fully cured yet. And so when you wash it, you want to wash it with that section down. So all that resin gets out of the intaglio surface. So when you seed it, you don't have any excess resin that cured in that area. To help with the chemical process, there's a heating of about 5 to 10 minutes, depending on the type of oven that you have. LuxCreo does provide these, and it actually cooks off some of the outside barriers that can cause, just issues with the cure. And then the cure itself is about 10 minutes, and you go through there and it works out just like anything else. I mean, this is, if you do 3D printing, you're familiar with a lot of these processes. If you don't do 3D printing, you print the item, you wash the item, and you cure it. The only difference with this type of material is that you add that 5 to 10 minute heating apparatus to really cook in the thermoform properties of it. The ability to do, we talked about this a second ago, the supports themselves are like right on the edge. And so you can see in the second piece right here, you just polish off the edge and it's ready to go. This is an example of an EMA appliance that's being cleaned off, and you can see how that just came right off on the left side. And then the last thing you want to do, just like you do with all trays, is you clean it. Make sure you clean it off really well. You can also heat these. A lot of times, if we will, our lab tech will actually put these in hot water just to ensure that any deformation that's happened during this process is the trays go right back to exactly where they started. So we know that that's going to work out extremely well. Okay, so you can see here, I've kind of broken it down for you about how much time it takes, labor time. Now, you can't get a tray in 6 minutes and 41 seconds. You can have your lab tech understand that this is the amount of time they're going to spend with the trays. And so that gives you a better gauge on what's happening in the workflow. I know that my lab tech is super excited. I taught him about 6 months ago how to do this because I was doing a lot of this because I wanted to understand the process better. And then lab tech was newer and I didn't want to throw too much at the lab tech at once. And now Eddie is just on top of this. He loves it because if we have 10 cases coming in next week that need aligners, if he's looking at his lab shelf and he's got 5 to 10 models on each of those cases, he's got to take the models down, thermoform them, cut them out, polish it. It's a lot. Whereas if he's got 10 cases that are all DPA, takes it down, pops the supports off with his hands, polishes it, cleans it, and puts it away. I mean, it's a dramatic change in the amount of time it takes to labor time it takes to create, which improves our throughput, which reduces my labor cost, which increases the amount of use. Like if I have a case of like 10 trays, I typically would just send that out to USmile and have them print them for me. I used to stop at 5 because of the capacity of my lab tech, the number of hours per week I have my lab tech. Now, that same capacity, those same hours can create a larger throughput of trays. Fantastic. That's what I was looking for. Part of it, the cost, because the labor cost goes down and because the material cost goes down, I'm able to now realize a better cost over thermoform in my office versus a direct print appliance. And most of that is one, I'm not paying for model resin. Two, I'm not paying, now if you're using a different type of plastic, I use Endura, which is a little more expensive, but I think it works. That's why I use it. The amount per STL of the $5, and then it yields a little bit different depending on the learning curve and things of that nature. But the ability to dramatically reduce labor and material costs is what really helps us realize true savings. I mean, would you like to save 20% on anything in your office? It's kind of nice to have that ability. Attachment templates. I still use attachments, like I said, and this is the way we do it. I still print the model because the resin tray, the smart tray, if you put composite in it, it's going to stick to it. And if you put a whole bunch of separating medium in there, you may not have a proper attachment design. And because these trays fit the attachment so well, you don't want to mess that up. So I still print one model for that. We use an O3AO coping material. The coping material is the same stuff we use in dental school to make temporaries so that it doesn't stick to the actual composite trays. And it's very simple to do. We're dramatically reducing the number of attachments that we need, but this is still a step that we use in our direct print process. Waste reduction. Waste reduction is a huge piece. The ability to not have this big model. I mean, how many reefs are there off Costa Rica? If you've treated 10 million cases, what is that? 600 million models? I mean, that's a lot. I mean, I know that some companies are now moving to nylon models so that they can be recycled, which I applaud. But there's a tremendous amount of cured resin in trash cans and God knows where they are, but there's a lot of it. And so the ability to only have about 8.7 grams of material, and then that's the only piece that you're using versus about 30 grams, you have a pretty large reduction in the amount of waste that you're creating as an office. So some people care about that, some people don't, but at the end of the day, we all kind of should because that stuff just builds up over time somewhere. Even though I might not be able to see that somewhere, that somewhere may be coming close to a friend near you. So it's good. I feel like it's always good to reduce the amount of waste that we're creating. All right. What I'm going to do now is I'm going to show a few patient cases. Some of these cases, the first one I'm going to show is a case with a maxillary midline diastema. Pretty straightforward case. The question in this case is, if I squeeze the upper 2 to 2, the overjet is about 1 millimeter. There's contact lingual to number 7 through 10. So the only way I can really close that diastema is with some slight intrusion of the upper and lower to create the overjet to close that space predictably. And so the way I designed it is this is one of our research protocol cases where I intruded the teeth and I used the pressure points on the left lateral and a traditional attachment on the right lateral. And the question I had in this case is, will the laterals look the same or look like they're supposed to at the end? Will they look like the setup that I've just shared with you? Or will the tooth with the attachment work like it's supposed to, and the one with these pressure points or negative attachments, is that going to act like it wasn't even used? And so, is this a difficult case? Of course not. Is there still an opportunity for there to be issues? That's why I'm doing more cases. But in this particular case, I feel like we were able to get a really good position on the laterals. I felt like we were able to get a good control of the laterals. And I feel like if I treat this case, and I have treated this case again in the future, I likely wouldn't need any attachments, which is nice. The next patient that came in was really just crowded lower teeth, had a class 1 bite, and really just wanted to resolve lower crowding. We did use a little IPR. She was starting law school, wanted to go ahead and get this out of the way. Luckily, it only took about 3 months to get her lined up. We really didn't use, it says no attachments. We did end up using one on the video, and we did do a little IPR prior to tray 1. You can see that she has a fixed retainer that failed. I had not seen her before, but the glue had come off, and I believe she had the tooth move and then had somebody rebond the glue, and she's like, "This is just getting out of hand. We need to fix this, and I don't like the way it's looking." And so this was the setup. And like I said, I apologize. I did have no attachments. I did end up putting one on the canine there. And that's really just, did I need it? I probably didn't. Um, if I did this one again, I would put just a small little pressure point on the mesial of that tooth and maybe a little bit on the distal of it, a little lower to the gingival margins so that I can control that canine. But still getting into cases, some of the earlier cases I did, I still did not want to completely abandon some of the techniques because, like I said, these are paying patients in a private practice that I still want to make sure that I'm being realistic on the probability of success in these cases. But after learning and working with this material, we've seen some really great results so far, which we've really enjoyed. The next one was has a little more meat to it. I did avoid attachments in the aesthetic zone on the uppers. I did add a few more attachments to this case. Once again, going back to the fact that I want to learn. I want to understand by slowly avoiding attachments in certain areas so that I can kind of sneak up on the answer instead of just not doing any attachments and then maybe not knowing why it didn't work. If I have too many complexities going at the same time, it makes it a little more difficult to layer back and understand more clearly what's happening and what's not happening. And so Maggie came in and really did not like that lower incisor the way it was. Her upper tooth in photos, the upper right two, just felt like it was sitting back, and she just was overall unhappy with the way that her smile looked. And so you can see here, once again, this is an earlier case, and I used a lot of attachments and tried to avoid them as much as I could. If I had to do this one again, which I'm sure I'll see a case like it, I would not have done the attachment on the upper left canine, and really try in an attempt to completely avoid any of those attachments that patients typically don't care for. But at the end of the day, using the direct print aligners, we're able to create in 8 months a case that turns out really nicely for the patient. Now, two things need to happen in these types of cases. Number one, the trays need to work, and the patient needs to be compliant. Because if the trays work and the patient's not compliant, teeth don't move. And if the patient is extremely compliant, 22 hours a day, no question, and the teeth don't move, then the trays didn't work. But the fact that the teeth moved to the position I was anticipating tells me that one, the patient likely wore the trays like we asked him to, and two, the plastic worked. And so the question I hear a lot is direct print aligners, are we there yet? Well, yeah, it's moving teeth effectively and predictably. And I do not pretend to have all the answers on this. Hopefully, I've made that clear in this seminar. And at the same time, I know that it's working. And that's why I continue to find depths of what we're able to do with this aligner. Because if I had started doing this and teeth weren't moving, well, that would be the end of that. But teeth are moving. And that's pretty fantastic that we're tiptoeing into the idea that we are on the cusp of a true evolution of aligner therapy, which is really great. This is one that we looked at where the tooth itself, this is the case we saw a few minutes ago when I was talking about my workflow. And the the root itself is too far facial. And the periodontist thought, if I graft that, I'm not sure it's going to be as predictable or hold as well as I would like. And so, Bill, can you move this tooth? And I thought this will be a great opportunity here to show root torque because, root torque, I can get a CBCT up, I can do all these different things, I can show the crown, but to be able to clearly visualize using these types of negative attachments to move a tooth and to clearly see a change, because this recession had been here for about a year on the patient and was getting a little bit worse. I thought it'd be fun to be able to see it. So we've kind of looked at this video where we used some pressure points or negative attachments on the incisal edge of the lingual, and then a power ridge on the facial gingival portion of the tooth, creating a coupling force on the tooth. No attachments, just the ability to push on the tooth exactly where I want to push on the tooth. Now, an earlier slide showed that you can set this up and then you can thermoform, but the thermoform tray doesn't really engage the tooth very well, does it? You don't see the benefits of your digital setup when you do this and then thermoform. A lot of times you can use pliers that you heat up, that you make a dimple on, and a lot of us probably have done that. But this, you're able to actually create the dimple with a thicker layer of plastic. I had a case the other day I delivered, and I had a 0.5 millimeter depth of the power ridges and delivered it to the case, to the patient. She couldn't wear it. It was too much. I had to back up to 0.2 millimeters depth of the negative attachments. And she was able to wear it fine. And definitely she felt a pinpoint change in the actual tooth itself and how that tooth was being pushed. I mean, we know proprioception in the ligaments is very high, but she could really tell that there was engagement there. And there's nothing worse than giving a patient aligners and they're like, I don't feel anything. You're like, well, okay, we'll do a little more, but it worked out really well. So in this case, you can see that just in a few months, we were able to move that root more lingual to the point where the periodontist actually gave it a few months to see if the tissue would go back together. It didn't. And he did end up doing a graft in that area, but a graft over that amount of root and with the tissue on either side of it having the appearance it does, I and the periodontist believe that that graft is going to be highly successful in a young patient and hopefully serve her for a very long time. And so this to me is a clear indication that root torque in the buccal lingual dimension is very achievable without attachments. And once again, that the plastic works. Can I direct print something and it actually moves teeth? Yes, it can. Last one was a patient, the second to last one was a patient that came in and really didn't take very long. She actually was pretty excellent when it came to compliance. She did not need a refinement. She came in because she was going to get some implants in the lower left incisor area. And the dentist said, if you're going to get those teeth straightened up, you kind of need to do it now. And so we were able to then use direct print aligners with a ponic in that area and move those teeth into their proper position. Now, once again, I was still back then when I did this case, a little bit nervous about having nothing. So I put a little attachment on the canine. Patient barely even noticed that it was there. But once again, today, if I was to do that, I'd use negative attachments and not even need a actual visible attachment on the tooth itself. And you can see where the patient ended up. And I was really excited because, the patient wearing the trays that fit properly, that moved the teeth exactly where I wanted them to go was really exciting for me because I'm just like you. I'm a practitioner that, maybe you're not, but I'm rather skeptical after 20 years when it comes to new technologies. I've been hearing about technologies for 20 years now that, still are saying that they're improving. And I don't know, sometimes some technologies just I'm becoming very skeptical when I hear a lot of different marketing pieces. And so I like to really dig into testing the materials and understanding the materials. And this one really felt like a pretty big opportunity to get involved. So this is the type of results that I'm seeing in my practice. Another patient that I see a lot of, I see a number of adult patients, and one of the most common most common cases that a dentist will refer to me is a patient with worn anterior dentition. Teeth have worn away and super erupted, and the dentist really doesn't have the ability to restore those teeth unless the body of the tooth is put back to where it needs to be and the tooth is actually restored to its normal piece. So a case like this one, we ended up leaving that space open because of the patient's potential overbite, but we can see that there's a fairly, not super deep, but the wear on the lower incisors was considerable, and the patient and the dentist wanted to restore those back to their original form. And we can see here, through tons of studies and research, to do a little bit of overcorrection in those lower incisors to be able to put them in a better position to create some anterior open bite for them to restore the lingual surface of the upper anteriors and the incisal edges of the lower anteriors. I was really happy with the fact that we were able to get a really good overbite correction. I still struggle with that a little bit, putting a ton of attachments on teeth to get this incisor position. And in this case, the ability with direct print aligners to put those teeth in a very desirable position for the dentist to then restore. I know it's tough from this aspect to really see the opening. I should have probably grabbed a picture that showed it, but there's about a 2 millimeter opening between the incisal edge of the lowers and the lingual surface of the upper, which gives the dentist plenty of room to then manage that space and restore those teeth back to a healthier state. So some of the takeaways: active memory material enables thermal rejuvenation. Essentially, all that means is you put them in 98 degrees Celsius, 98, 99 degrees Celsius water, 5 minutes, they're going to go right back to the exact form, pretty close, 99% of the exact form of the day you gave it to them. The ability for direct print aligners provides superior tooth and attachment conformity. So all we're saying there is that they fit so much better than thermoform. Thermoform, the attachment, it kind of barely grabs it. The gaps, the different variability, we're able to control that completely with these types of aligners. The workflow takes about 7 minutes, less than 7 minutes. And so my lab tech is super excited about the fact that when he sees a whole shelf of direct prints, his life is going to be a lot better than thermoforms. He's going to have time to really manage maybe some other items that we've given that person to handle. And waste. I mean, the ability to reduce so much waste in this process is pretty exciting. So just, I jumped in and really have enjoyed every moment of it. And I'm looking for other people to join me. And please ask me any questions, send back any information. I'm just really excited about this entire process of direct print aligners and how we can move the patient experience forward and create a lot of predictability in what we do. So thank you so much.
Thank you, Dr. Layman. Great presentation. There are some questions coming in, but before I get to those, I'd like to remind everyone to use the question and answer feature in the control panel on your screen to ask any questions. First question, for a case without attachments, how can you guarantee the treatment will stay on track?
Well, a guarantee is a challenge. You can't guarantee a treatment will stay on track with attachments. It depends on compliance. It depends on your design of the case. Um, what I'm doing, and hopefully we'll be able to share with the rest of the world through publications soon, is the fact that if I can show that the negative attachments or the lack of attachments can produce the same efficacy of tooth movement, then you'll have a much better time in your practices understanding the limits of what you can do without having to test it out as much as we are right now.
Okay, second question, are there any tooth movements where you think fewer attachments improve predictability?
The torques, I think, are amazing. The ability to torque teeth with negative attachments, I've seen is very predictable. The ability to create pinpoint coupling forces on the teeth is much better. Distalizations, being able to use negative attachments for those are good. Extrusions, I'm still, of course, challenged with those with using minimal attachments. But what I've seen on extrusions is the fact that the direct print aligner engages the attachment so much more efficiently. The attachments do not need to be as large because large attachments are compensating for the thermoform um, shortcomings of being able to truly form to that attachment. So even some of the movements like extrusion, where I still would like an attachment, they don't have to nearly be as large or as obtrusive anymore with this type of material.
Okay, next one, how do you communicate the benefits of a no attachment approach to patients who might be comparing your treatment to traditional clear aligners?
Staining of the attachments is pretty high. Just feeling it on their lips. I think if I can avoid that for them, they usually understand that pretty well. And the fact that with good compliance, your treatment can progress much more efficiently.
Okay, regarding using technology and AI to optimize force delivery, can you expand on how these tools help you reduce or eliminate attachments in your workflow?
Well, AI is a smart computer. If I'm able to ask the question of a highly analytical device, instead of having to really understand the most optimal equation to ask a computer, if AI can translate my physical world question into an analytical mathematical model that it can then create that information and send back to me in a more physical world answer. That's where I think the benefit of using AI to understand these types of movements and amalgamate all of the studies that have been shown to be effective definitely helps me create the best straight line between current situation and treatment success for the patient.
Okay, and what advice would you give to an orthodontist who's used to attachment-heavy treatment plans, but wants to transition to a more streamlined, patient-centric model?
I would say to pick, like I'm doing, that's essentially what I did. Don't try to go all in all at once. Test yourself a little bit. Test some, like I did. I tested laterals that I wanted to make sure they didn't disappear on me. Yes, it worked. I want to try some expansion where maybe I'd place attachments and now I don't because the trays fit better. Um, Test it out on individual pieces of your treatment. And then once you have the proof of concept of individual pieces of your treatment, you can then start to coagulate those individual pieces into a larger concept of your cases. So before you know it, if you found that holding the lateral, rotating the canine, torquing the lower right two that started out lingual, if all those are working on individual cases, there's really no reason why you can't add those as a whole to a case to dramatically reduce the amount of attachments that you're using.
Thank you everyone for your questions, but we've run out of time today. If we did not get to your question, we will answer it after the webinar via email. Within 1 hour, we will send you a link to the recording of this presentation and instructions on how to access the free CE quiz to receive your certificate. Thank you to Dr. Bill Layman and our sponsor for this webinar, LuxCreo. Thank you all for joining us and stay safe.
Thank you.